Right, welcome everyone to the final pitches for Track D. Thank you for joining us. I know it has been a very long but very good weekend for all of you. We're all so excited to see all the ideas and projects that you've been working on for the last 48 hours. On behalf of the MIT COVID-19 Challenge, I want to thank everyone for participating in the challenge, and also thank our judges for taking the time to be with us today. Next slide, Michelle. All right, so I just want to start the presentation by going around and introducing all the team members who are going to be helping with the final presentations tonight. As all of you know, my name is Dania Day, and I'm your track lead for Track D. I am also a physician scientist during my day job, and I do a lot of work in the diversity, equity, and inclusion space. We also have with us today two members of the challenge organizing team who will be helping with the different tasks during the final presentations. Michelle and Michael, I'm gonna turn it over to Michelle to introduce herself.
Hi everyone, my name is Michelle. I'm so glad to be here with you today. I'm currently an MBA student at MIT, and I'll be helping to advance the presentations today, so excited to be here.
Thank you, Michelle. Michael?
Hi, my name's Michael. I've been with Hacking Medicine about 3 years. Did a BME undergrad, and my day job is account manager at a tech company.
All right, thank you, Michael. Michelle, if you can advance to the next slide, please. So just to remind everyone what we did in the last 48 hours. So as you all remember, we started with the pitching that happened on Friday night. And then team formation happened between Friday night and Saturday morning. Then you spent most of the day yesterday hacking. We provided you with all the feedback through the different practice pitch sessions. And I have to say, I was really amazed by all the progress that all the teams have made between the first and second practice pitch sessions that we did in the last 24 hours. Then you took our feedback and iterated, and there were some really amazing results that came out. And we are at the very final stage of the hackathon today, which is the final presentation. So we're all looking forward to hearing all the great ideas that you have come up with. Next, please. So we're very fortunate today to have an excellent panel of judges with us. We have Ethan Gershon, who is a clinical safety officer and physician executive at InterSystems. We have Ib Badejo, Senior Director of New Ventures at Johnson & Johnson Innovation. We also have Donald Kripke, Medical Director at inrecovery.org. We have Canon Dagdevirian, Assistant Professor at the MIT Media Lab, and Kate Donovan, Clinical Director of Innovation at Boston Children's Hospital. Again, thank you all very, very much for taking the time to join us today and for serving as our judges for this challenge. Next slide, please. So just to summarize for all the teams today, our judging criteria, we're going to be assessing on 4 different areas: impact, innovation, implementation, and presentation. And specifically, we're going to be looking at a couple questions. Does your solution address an important challenge identified in the prompt of this track? Does the solution consider user experience, interface, and service design? Could the solution possibly be implemented by one of the challenge partners? And finally, does the team have a diversity of backgrounds that will lend itself to the solution area that's being proposed? Next slide. So just a few logistics for all the participants. So these presentations, as I mentioned, will be recorded. If you have multiple team members who want to present or answer the Q&A, please raise your hand. We're gonna need to unmute you. So just raise your hand as we announce that you're about to present, and we will unmute you. If you're not planning to present or to answer any questions, you do not need to raise your hand. The order of the presentations, as I mentioned in the Slack channel, is going to be random. We use a random number generator to come up with the order, and we will tell you who you are, who is going to be doing the presentation, and then we're going to tell you who's going to be up next. So you're gonna have one presentation gap to get ready and prepare. Again, we're gonna be sharing our own slides. You will not be able to share any of your slides. We'll be sharing a master deck that we have prepared based on the slides that you already submitted at 11:30. So as I mentioned, raise your hand, and when it is your turn to present, we will actually unmute you, and you can turn your video on during your presentation. We will have to flip the slides for you, so just make sure to tell us next. And the judges in this track will be picking 4 winners. I'm just going to announce before we move on that our first presenter is going to be COVID Protect, for that team to get ready and raise their hands. Next slide, please. So just to summarize very briefly, every team who's presenting, or the members who are presenting, are going to raise their hands. We're going to unmute you, and you can turn your video stream on during the presentation. Otherwise, keep your video stream off. You have exactly 3 minutes to present, as we did in the practice pitches this morning, and the judges will only have 2 minutes for questions. And Michael is going to be keeping track of the timing. He's going to tell us when it's 3 minutes. He's going to say time, and after, at the end of the Q&A session by the judges at 2 minutes, he's also going to tell us time, so we can move on to the next team. We have a total of 21 teams presenting, so it's very important that we try for all the participants to stay on time as much as possible. Before I start with the presentations, I just want to check in with the judges, make sure all the judges have access to the form for judging. Judges, are you all set?
I'm all set.
All right, thank you.
Me too. It's all good.
Yeah, where's the forms?
So if you go to the Slack channel, it is posted there.
Thanks.
All right, and I think you have Kate Donovan. Are you all set too?
All set, thank you.
All right, perfect. I know we're just looking for one more person. Let me just check. Is Mr. Kripke on? All right. All right. With that, we are going to go ahead and start with the presentation. So I'm going to go ahead and unmute for the first team. We have Siddhant.
Hi, can you hear me?
Yes. Go ahead.
So should I start?
Yes.
Awesome. Just one quick note. So team right now, first team up is COVID Protect, but coming up is team 70, Respire. So just be ready to go after this group. Thank you.
All right, you can go ahead.
So, hi, here we are, COVID Project, and we are here to change the game in rural healthcare. Let me tell you a real life scenario. Next slide, please. My 67-year-old uncle from a remote village can't travel to the nearest hospital due to corona outbreak for his minor illnesses and diabetes mellitus checkup. Next slide, please. Next slide. And it's not just him. Census says 87 million elderly people who live in rural India, and out of them, 48 million have comorbidities. And the fact everyone should look upon, 64% of them don't have access to telemedicine yet. Who would provide a medical solution to them? Next slide. So here we come with an app, come kiosk, come booth-based, one-stop solution for the entire problem. And our solution is really simple. Next slide. Yeah, here we go with our solution. For the non-COVID patients who have access to the app, you can simply use the video-based telemedicine service, the consultancy outpatient service. But who don't have an access to the app, don't worry at all. We have a booth appointed with a technician over it. And if you are afraid that you'll catch corona over there, no need to worry at all. COVID probable or COVID possible patients have to be tested first in the kiosk. If they are positive, they are referred to the frontline healthcare. And if they are negative, they can use a setup as they want. Next slide, please. And yeah, now I come. Everything sustainable, I would say. To your surprise, there's a stat which says 35 to 52% of people who visit outpatient clinics are for illness, which can be cured in without procedures and just by empirical and supportive medical therapy. and the mortality rate for elderly is 57% as compared to the 5 to 11% for the rest. So covering the low cost, one-time investment, and lifetime source of revenue for such a huge consumer base, this is going to be a win-win situation for every investor. And we can start it as a public-private partnership in the beginning as well. Next slide, please. And now comes my team. Oh, it was superb working with all the guys with such a diverse background: an electronic engineer, medical researchers, and the experienced hand project management and implementation consultant. Next slide. Plus the timeline which we have for us. Next slide, please. Is simple. Is super simple. Identify the previous slide, please. Identify the geographical setup. 1 per 10,000 population. Get the workflows done. A minor training and boom. We enter a revolutionary and unexplored sector with a potential of tremendous growth and around 80 million consumers within a country. Thank you so much.
Thank you, and we'll turn it over to our judges for questions.
Hi, this is Ethan. I have 2 questions. What's the revenue stream to support this, and who are your competitors?
The revenue stream for it is really, we have kept it really simple. So about $500 will be used to set up a single booth. Plus then we are expecting 100 patients per month, which would give us a revenue of around $250. This is just a rough estimate. Plus private healthcare would be investing in us, and it can be a government plus private setup as well.
Hi, this is Canon. I have also 2 questions. How do you plan to store all the data, and who is going to access the data, and how you plan to communicate with different populations in the same country and as well globally?
We'll be having a central database which will be there. We'll be connecting the COVID booths plus the app. So any consumer of ours will be getting us straight data to the central database. So every data will be there at one spot.
Hi, this is Kate. I have 2 questions as well. My first is, how do you see this integrating with the physicians that may be prescribing medication? And the other is, how are you going to deal with infection control of the booth itself?
Okay, for the infection control part, I would like to answer. We'll divide the patients into corona probable and corona possible patients that the Indian government or the local government has set up. For those patients, they have to be first tested in the booths. If they are positive, they are straightly sent to the primary healthcare services. And if they are negative, then they can use their app. So in such a way, we can protect excessive contamination. And what was your previous question? Can you please ask the first question again?
Sure. How will the results integrate with their medical staff?
And then this will be the last question, please. Thank you.
So how will the physicians get the results?
The physicians will get the results. The physicians who have been assigned as our consultant physicians for our application-based service will be having the access to the results. Plus, there will be an uploading service which can be there. So the previous records of there can be uploaded at the time of consultancy.
Okay, thank you.
Hey, thanks, guys.
Just before we move on, I'm just getting some requests that people are having trouble raising their hands. Just before we move on, I'm going to ask participants to try raising their hands. And if you're having trouble finding the raise hand, okay, I see a number of people. So if you can just lower your hands, whoever raised their hands. If you're having any trouble finding the raise hand button, just send us a message in the chat. No one is able to unmute themselves but the hosts. So we will unmute you once you raise your hand. So everyone just lower your hands. And then just for the next team, only the members presenting raise your hand.
Okay, awesome. So our next team is Respire, Team 70, and then coming up after them is D38. So on COVID, please be ready to go next.
All right, so who's presenting from Team Respire? Raise your hands. If you can't find the raise your hand, just type in the chat so we can find you. Shivam, okay. All right, Shivam, you're unmuted.
Hey guys. Okay, cool. So yeah, so our team is Respire. It's by me. I'm a senior engineer at Bloomberg. Divyam Siddharthi. He, as you can guess, he's my younger brother. And Nikhil Vumadi, and he is an engineer at JP Morgan. So our app is Respire. Can we go to the next slide? Now, imagine that you're a medically vulnerable person who lives by themselves. You begin to feel slightly worse, and you suspect that you've contracted COVID-19. What do? Do you go to the hospital? You're not sure if the condition is serious enough, or you're nervous that your finances might be a problem, or that you might get sick at the hospital itself. Do you call a family member or a close friend to watch over you? Well, you don't want to get someone else exposed to COVID-19, so that's not the best idea. Do you do nothing? Well, you're worried that overnight your condition can worsen, and that you might not be in a position to get help. So next slide. So oximeters, so now we don't really have great options. What you can do is you can buy an oximeter on Amazon for $20 to $100, and you can plug that in. Some of them have a functionality where if your oxygen level gets low, it'll actually beep on the app. But there's not that's not a great solution. For that, if you are in a dangerous position, there's a lot of factors that matter. It could be altitude levels, your age, your other pre-existing conditions. So, and on top of that, if there is an emergency, there is no functionality to reach authorities or family members. So can we go to the next slide? So this is our app, Respire. Our app detects 3 different metrics. So we take data from your oximeter, which has your blood O2 levels, and it has your heart rate. We also take in some user information as well, your age, any pre-existing conditions you might have, your gender, and then on top of that, we built a machine learning model that also is able to detect coughing. So when we see that there is a slew of things that could be pretty dangerous, we then contact medical providers or an emergency contact that you have provided. So our app uses, our machine learning model was created in Keras, which is a library, and then we use Twilio to send our SMS notifications. So if we go to the next slide. So here, if you look on the left-hand side, you can see that we collect, this is also kind of the UI for our screen. We collect in their age, gender, height, weight, and also some pre-existing conditions, and they can provide an emergency contact for who would be the first person we'd send a message to. Now, that second page, we'll get back to that. So can we go to the next slide? Okay, so here's actually kind of what our app looks like. So when you go to the monitor screen, which we're on here.
Thank you, and time.
Okay. Sure. I thought we'd have more, but okay.
We'll turn it over to our judges.
I have a question. How do you protect patients' data?
Well, so for protecting our patients' data, the way that we were envisioning it would be that that a lot of this stuff could be done on the client side. And so only when we deem things like the machine learning model that we have, that is on the back end, but it's only taking snippets of basically the patient's data like the audio data that we're transferring over. That's the main part that we're transferring over. That for that, we would just send over the data, and then it gives a response. If it's not dangerous, then we don't even store that data. It's only when we think that there are dangerous amounts of data. Most of the stuff will be kept on client side though.
I also have a question. Could you please clarify if you have physical sensors to measure such vital signs?
So sure. Yeah. So there's oximeters, which are basically tools that you can put on your finger, and that will give you your blood. That'll give your blood O2 levels. Like it's not as accurate as being in a hospital itself, but it'll give you your blood O2 levels, and it'll give you your heart rate. We use the microphone from your phone, to track your coughing. And this is something you would leave on overnight on your bedside.
What is the cost of the entire system?
Overall, things are pretty cheap. The machine learning model, I think if we wanted to scale this up, we would need to basically get better data. We provided a link for where we got the data from right now. We were able to find free data, but it wasn't that great. Our machine learning model, if you make a really loud noise, sometimes it can detect it as a cough. So we need better data, but to send out an SMS, very cheap. And then there'd just be general website hosting costs.
Great. Thank you for the questions. Thank you for the presentation.
All right, thanks guys.
All right, so up next we have on COVID, Team 38, and then please be ready, Riskified, Team 12.
Can you please raise your hand? Okay. All right, go ahead.
So we're a team on COVID, and we're here to help cancer patients on their journey to remission. Next slide, please. So the current problem is that cancer patients undergo immunotherapy and they're at high risk, and regular staff are avoiding going to hospitals. And there's regular appointments that are being canceled. So usually these people are notified and they're being noticed. So for example, here you can see an image of a person who's in remission and she's ringing the bell, but now these patients are not noticed. Next slide, please. So we have two problems. The cancer patients under remissions have gap in the regular checkup, and patients that are undergoing treatment need to also receive follow-up. So the problem is that relapse identified after 1 day leads to a higher chance of survival. So we need to predict that. Next slide, please. So our solution is a crowdsourcing platform. And here we can just show you a snippet of the platform whereby we prevent the onset of the cancer happening again. So we ask questions like, what type of cancer would you have? When was the last treatment? When was your last checkup done? Next slide, please. And then for the response for volunteers, so we can match cancer patients and volunteers so they can recover from their treatment. If they need medications, we ask questions like, do you have experience with cancer? What are you, a healthcare worker, family member? Are you a cancer patient? How old are you? Do you have a previous medical condition? Next slide, please. So this is overall our business model. So we want to connect the data that we get with the governments, hospitals, and pharmaceuticals. So we can provide a real-time data through electronic health records. And for example, for pharmaceuticals, for example, we can say, okay, what treatment was received? And then they can say, okay, drug X, for example, ended up with a relapse within 1 year. So we would share that data with pharmaceuticals. Next slide, please. So this is our team. We bring expertise from biomedical engineering, computer science, data science, and we have an advisory board, oncologist specialist, as well as a nurse to showcase and help us through that process. So next slide, please. Next slide, please.
I'm not sure if her connection is frozen. Michelle, are you still with us?
Sorry, just lost connection. I'll advance the slide now.
Okay. Thank you.
Okay. So we are here to guide cancer patients through treatment. We have a cross-platform right now, a web app with an open link where you can fill a form and submit it. And we want you to be on the lookout for an SMS integration where we can push the form in order to increase the visibility of our platform for people without access to internet to ensure a global outreach. Thank you.
Hi, this is Ethan. I'm sorry, somebody else has a question?
Go ahead, Ethan. I'll ask her.
Okay, so what's your revenue stream and who are your competitors?
Yes, so currently our competitors include crowdsourcing platforms like HealthX and global cancer observatories, and we also have the NIH, which is crowdsourcing that data, but no one's actually providing this niche service that we have, especially with the onset of COVID and cancer patients being immunocompromised. And in terms of the revenue stream, as I mentioned, we're gonna collaborate to ensure our longevity and sustainability. We're gonna collaborate with the government, so we can provide resource allocation so they know where they can allocate those resources, or let's say they want to open, they want to have more cancer centers, or they want to increase the supplies for cancer patients. So they would benefit from our data, as well as hospitals like Mass General, Johns Hopkins, all those FAPES hospitals, and also pharmaceuticals that would benefit from the treatment details and medication related to the relapse information for cancer patients.
Thank you.
Thanks.
One of the struggles with crowdsourcing is that it's hard to get folks to fill these out. So what kind of incentive are you giving patients to do this?
Yes, exactly. So the main incentive that we have here is number one, the preventative treatment, where we connect cancer patients with healthcare facilities, because we understand that, okay, you know, I'm cancer free, I can live my life, but the problem is that cancer can show up again. And unless you're fully like 5 years into your cancer treatment, then you're considered like cancer free. And these patients, for example, we're going to use in our second platform, which is the ongoing treatment for those patients who are currently not on remission, but more that are actually recovering from the treatment. So we have a matching platform. So it would be like a matchmaking platform for volunteers, whether it's health workers, family members, caregivers, you know, my mom, my dad, you know, they could help, or healthcare workers, maybe that have retired, or cancer patients who've done well, like I mentioned, that, you know, more than 5 years at no risk.
Great, thank you, and time.
Thank you.
Thanks.
All right, up next is Team Riskified, and then after them, we have Team 17, the COVID Zebras. So if you can raise your hand so that Danya can unmute you.
And just for the judges, is this the third or the fourth presentation? I've lost track already.
This is fourth.
It's fourth.
Thank you.
All right, you're unmuted. You can go ahead.
Perfect. So we are Riskified, and the people on our team are me, Ananya, Shruti, and Abdul. Going to the next slide. So addressing the problem, underserved populations are disproportionately affected by the illness, and we would like to see these trends and see exactly how we can help these populations. In our opinion, hospitals need a method to better target individuals during their treatment plans and anticipate cases, which has implications of hospital threshold and capacity. As you can see, just a general outline of our project is going to be that we have the bigger population that is affected by COVID-19. We're going to come up with a filtering system that's going to give us high-risk individuals in order to better target these people during care teams and treatment. Next slide. We will be working behind the scenes to make sure that hospitals and medical professionals can give these patients the best care possible, these high-risk patients, and we will arrange for the care management based on them. How this is going to reduce costs is that we have a more targeted approach in treatment, which will streamline equipment and hospital staff, mainly for those who require it and anticipate it, which will give us more time to be prepared. Demographics are the most important and inherent aspects of a person that will allow us to find these trends and continuously update our system. As you can see in the graph that I have attached on here, these clusters will tell us the populations and demographics based on a severity scale. Next slide. So we're going to use an amalgamation of these types of data. EHR structured data is going to be the examples of specific values such as date of birth, medication, lab results. EHR unstructured data is going to come in the form of doctor's notes and unofficial documents, and open source external data, which comes in the form of research journals and researches done by universities and everything. And this is in order to make sure that there are no holes or contradictions in our database. And EHR has implications on privacy issues, and we would like to make it a point that we will run according to hospital privacy issues and HIPAA laws. We'll make sure to sign contracts and ensure patient privacy. One idea that we also had is to censor names and make sure that we're only using demographics. Next slide. So these are the risk factors. These are the type of factors we'll be looking at. Just to point out that we will be looking at age, race, ethnicity, residential areas. All of these have been proven to be very important factors to take into account. It's exactly what we will be researching and finding through the hospital. And in terms of implementation, we will continuously update our system based on new patients, and hospital and clinics will be our users. Care management team is going to be based on severity, and we hope to target new patients and admitted patients. And for people who are not even sent in the hospital yet, we want to try and spread out this information to make sure that people also in their homes can see if they fit into a lot of these demographics and take precautions if they do fall into a lot of these categories. And just to point out in the next...
And time. Thank you. Open it up to the judges.
Got a question. How do you monetize this? Or what's your source of revenue?
So we will be, this is Abdul. So our approach is going to be the tiered approach depending upon the type of hospitals, because for small practice, we'll have a fixed price model. For large hospitals, we'll have a model based on the number of patients and the size of the data basically. So that we'll have a tiered approach. For small practices, we'll have a fixed price model. For larger practices, middle and large, we'll have a data-based approach, and depending on how much data they have.
Thank you.
So what differentiates you from other players in this area?
As you know, this is a new issue, and a lot of new players are coming in. A lot of hospitals are trying to implement the solutions as well. But I think our solution gives this as a unique solution where it is separate from the EMR system, and hospitals can plug and play into their systems as well. So we have data pipelines from all the EMRs, either it's Epic or Cerner, and we can have a separate system which can also integrate with the other hospitals. So we'll have a unique solution which we can provide to any hospital basically.
All right. Thank you for the presentation. Thank you for the questions and answers.
Thank you.
Thank you.
All right, next team up is Team 17, the COVID Zebras, and then after that we'll have Team 28, Spread Warrior.
All right, go ahead. Philip, you're unmuted.
I don't think Fuang is. He's our speaker.
I do not see him raising his hand. Let me just, Fuang, okay. Okay, go ahead, Fuang.
Okay. Okay. Children like Dolapo in rural communities such as Awe, Nigeria, who have chronic diseases such as sickle cell disease cannot access the urgent medical care because there is no contact-free delivery of medical supplies. 80% of children in Nigeria who are born with sickle cell disease will not even reach Dolapo's age. Next slide. We are COVID Zebras. We care for medically marginalized communities. Next slide. In Nigeria, sickle cell disease affects 6.2 million people, and there are about 150,000 children born annually with the disorder. 70 to 90% of them will die before they reach the age of 5 because these rural clinics lack sufficient resources. COVID-19 exacerbates the sickle cell disease because those patients are already immune compromised and they request a constant supply of medicines. Next slide. We aim to reach every Dolapo in Nigeria, taking drugs from the megacities to the medical camps via trucks, then programming drones to send out prescriptions as needed. Next slide. So our time frame for implementation of the seed fund is 24 months, and our seed fund is $200K and will serve approximately 2,000 sickle cell patients. So the funding is broken down into 30% for R&D, including software, 35% for staffing and administration, 35% for marketing, and there's going to be over 6,000 villages in Nigeria impacted. Thus, piloting the project provides viability and sustainability post-pandemic as well. Next slide. Our business model is centered around local partners because of their established infrastructure and local knowledge. It will help sustain their communities as well. We'll be collaborating with NGOs, including many of our event sponsors, for seed funding, among other things. To keep the process sustainable, we will use government contracts to fund the shipment of drones and the construction of drone hubs. We plan on using a drug revolving fund, which is a tiny markup on drug prices, to ensure that medicines and PPE are available. Those are part of a revenue stream, and the Nigerian government will realize value and returns through the overall reduction of costs for their Ministry of Health. Next slide. Nigeria is the launching pad for our solution, and we have already identified some potential partners. We'll be partnering with an innovative sub-Saharan Africa partner, including a drone delivery startup and an emerging shipping solution. Next slide. So this is our timeline. The most critical step here is collaborating with partners for seed funding. We're looking to complete the pilot by Q1 of next year. And after that, we're looking to expand into other parts of rural Africa. And this model can also be applied to other rare disease states as well. Next slide. We're extremely passionate about the solution and are motivated to better the lives of the medically marginalized patients such as Dolapo with sickle cell disease during and post-pandemic. Thank you.
Thank you, judges.
Yeah, I mean, you know, using drone to deliver medical supplies is well established, you know, it's around. So what differentiates your technology from other drone delivery of medical supplies? Can you hear me?
Hi, yep. We were just looking to see who's going to answer the question. This is Kevin. I think that what's differentiating us is we've seen these companies out there within Nigeria trying to get started. What we want to do is integrate them with other transportation systems, integrate them with the medical system, and come in with some of the capital and expertise and perhaps education that can be put around it to help them reach their tipping point and actually do what they're trying to do. The company that we've looked at is Aron, and they're fairly new, and they're starting to build the infrastructure. We think they just need a little boost.
And so what makes you able to offer this integration, and who are you competing with to offer it?
So we have a lot of business. Business partnerships that are set up with the local community. So some public, private partnerships to keep our model sustainable. A lot of work with like local communities and kind of providing them more technology so that they can support those rare diseases even post-pandemic. If anybody else has something to add from my team.
All right. Thank you, COVID Zebras, and thanks for the presentation and questions.
All right, thank you.
All right, up next we have Team 28, Spread Warriors, and after them we'll have Allo Health. And for the judges, this is the sixth team to present.
All right, the presenting team, can you raise your hand? I have Bhakti. All right, go ahead.
Can I start?
Yes, go ahead.
Okay, should I start my video?
Yes, you're ready, go ahead.
Okay. Next. Meet Ram, a daily wage worker who earned $2 a day before losing his job due to COVID-19. His house in the slums of Mumbai is flooded due to heavy rains, and he's running high fever with chills. He goes to a government hospital despite fear of contracting COVID-19, but all beds are full and he cannot afford a private practitioner. So he goes back home hoping to heal on his own. In the next 2 months, about 10 million people in India, like Ram, are expected to suffer from diseases caused by flooding due to heavy rains. Next, the slide after this. Meet Dr. Raghuram. Dr. Raghuram is a retired physician and my uncle. He's sitting at home watching news about COVID-19, feeling helpless as he is unable to help in any way. Next. To relieve the burden on an already overburdened healthcare system due to COVID, our solution, Tele-Aspatal, provides telemedicine support to patients suffering especially from diseases caused due to heavy rains to doctors sitting at home. Next, we will have 2 platforms, a voice bot and a website for 2 different target populations. The voice bot is for low-income, health illiterate groups with no access to computers or internet, whereas the website is for health literate people with access to internet wanting to have a face-to-face conversation with physicians. Next, our platform will first verify the credentials of doctors who register on their website. This data will be used for patient matching later. On the patient side, low-income patients without access to the internet will reach out to their local accredited social health activists. These ASHA workers will call a hotline that uses natural language processing to match patients to physicians based on regional language requirements and disease symptoms. For regular patients, this will happen based on a form that they will fill on the website. Next. So here is a look at the user interfaces for doctors and regular patients. We will be keeping this simple to increase ease of use. Next. The biggest impact of the technology is to prepare India for an expected surge of seasonal diseases in monsoon while hospitals are struggling to keep up with COVID. We want to make sure vulnerable groups get care without having to go out and come in contact with COVID patients and carriers. Next. Our business model is bolstered by our aim of improving convenience, cost effectiveness, and safety. With monetary help and guidance from partners at the MIT COVID-19 Challenge, we believe we can help a model that will help generate revenue from regular patients while providing the best solutions for vulnerable groups. Next. Finally, our team members, having lived in India for most of their lives, are first-hand witnesses to these problems. And with a diverse skill set, we will be able to provide expertise in designing a solution that can be implemented to help millions or even
and
millions.
Time. Thank you.
Yeah.
Open it up to judges.
How would you confirm the credentials of the physicians and protect them from malpractice?
There is already a portal which is used in India called Practo, which also uses a credential verification system to verify the credentials of doctors. So we will be using something similar to what they have been using for so long on our platform.
And how will you protect them if there's a malpractice situation, if they're voluntary?
So I think this answer can be given by my colleague Muskan.
You can go ahead and try answering the question.
Okay.
Sorry, he was not unmuted.
Okay. Hello. What is the question? Can you please come again?
How would you protect the physicians from malpractice?
Okay, so when we will be entering the patients for the by on our website, then we will having some verification system for them also. So if there is some malpractice, then we can track the patients, and then we will have some rules and regulations for that. So there will be lesser chances of that.
Who are your competitors? Who's already doing this?
So this is supposed to be a not-for-profit effort. So even though we are looking to generate revenue to mainly cover our operational costs, we are not really looking at it with a profit point of view. So far, there have not really been efforts directed in this particular domain. If there are any telemedicine efforts, they are generally employed in bigger private hospitals using
that's
existing
time.
platforms.
Thank you.
Thank you.
Okay, up next we have Team 9, which is Allo Health. And then please get ready, Team 14, Banga.
Hi, can everyone hear me?
Yes.
Yep, we can hear you.
Okay, thanks. Next, please. Maria is a 52-year-old woman who suffers from diabetes, asthma, and depression. She needs to eat healthy to keep her glucose level stable and enhance her immune system. Now, Maria is also a high-risk COVID patient. She's afraid to buy essential groceries out of fears of contracting the virus from the groceries themselves. And that's if she could get to a large, affordable grocery store anyway, which is difficult because Maria doesn't drive. She's also wary of public transportation and lives in what's known as, next please, a food desert. While we often think of this as a foreign problem, it happens to families in our own backyards. Next, please. In fact, there are nationwide hotspots for food deserts that are only seeing intensified disparities because of now broken supply chains. While many are scattered in the South, this is also a local problem for us here in the Northeast. Next, please. The impact of COVID takes this further, not only by impacting those who suffer from chronic diseases, but also communities of color. Prevalence of obesity is higher for Black communities, leading to more deaths. This necessitates a solution that is also culturally relevant for better adoption. Next, please. And right now, grocery delivery services have refrigeration issues and are costly. Food banks require continuous volunteer support, and nonprofit grocery stores require grants. We need something that is both accessible and affordable. Next, please.
Our health solution is to make hydroponic farming more accessible so we can bridge the gap of healthy food and COVID food insecure communities by providing affordable and sustainable nutrition. Hydroponic farming involves soilless farming by growing plants in compact water nutrient solutions. Next. Allo Health is a simple, easy-to-use platform that allows users to request do-it-yourself kits and support to start hydroponic farming, including an optional subscription to replace nutrient solutions. In the initial phase of our mission, we will begin with our business-to-community segment, which includes the options of 3 kits, all priced under $15, and each with different size produce yields. Next, please. The second segment, which we will take place later in our expansion, is business to business, where we partner with stakeholders like farmers and scale hydroponic farms that can be set up on urban rooftops and greenhouses in countryside and rural areas. Next, please. We are looking to pilot our project in Philadelphia, where over 80% of those living in food deserts are currently not living near an active garden or farm. Next, please. Food insecurity is a common theme for people like Maria in Philadelphia, the Northeast Corridor, and the US as a whole, which means there's a large target market for Allo Health products. Next, please. Allo Health ensures there's an easily accessible source of fresh food without paying a price in money or health. Next, please. The team behind Allo Health is a committed and diverse group of students, startup innovators, physicians, and computer scientists. Next, please. So to make Allo Health a reality, we are asking for $5,000 in capital and the support of MIT's various partners, some pictured here. Next, please. With your help, we can ensure that nobody faces food insecurity during this pandemic. Thank you.
Hi, this is Ethan. I'm curious about the nutritional balance, the nutritional count. I'm sorry, in critical care medicine, we often talk about calorie count. Just as you know, is the patient getting enough calories? Do you have a sense of sort of how much nutrition you can provide per, say, how much square foot of rooftop? And is that number large enough to make a difference?
Is Shema or Kevin able to take that one? Yeah, Shema, can we unmute Shema,
please? Sure.
Hi, actually these hydro plants are really like they're in this one small room, like in 20 meters square, place, you can produce large amounts of like enough for at least 10 families food, meaning that lettuce, all the green products, which include all the required vitamins for the immune system, all the essential elements like zinc and iron. Like a rooftop garden can be enough for at least 10 apartments.
Thank you.
And sorry, just to quickly clarify, the caloric surplus that we usually see in these communities from fringe foods is also going to be replaced with these additional micronutrient benefits from hydroponic plants.
Hi, I also have a question. In addition to technology and kits that you provide, you also offer training for the users how to use those kits?
Yes, so that's provided in two ways. So one is going to be with our DIY kit manual, and the second is through our app. So if Raghava, you want to take that?
Yes, so we are gonna develop an app for it. Is will be guide us on education purposes as well for the beginners kids, because they can able to guide us and we can implement some machine learning algorithms so that like as robot chatbot systems, so that they can have some any problems in between. Suppose they are some facing any problems during this beginner kids implementation stuff or installation. So definitely the chatbot will be helpful for them. So they don't need to run
Great.
about for the customers.
Thank you. Thank you.
Thank you.
Yeah, thank you very much.
All right.
Michelle,
All right.
I think you're
Next,
unmuted. Yep.
so up next, we have Team 14, Banga, and then coming up after them, Team 50, One Health for All.
All right, go ahead.
Slide. Next slide. Okay. This is a story of Rachel and her pregnant sister who faces the problem of health disparities in Africa due to unequal distribution of resources. Most health resources are allocated to other regions, leaving her community underserved. More than 1 billion babies die before the age of 1 month. Also, sub-Saharan Africa accounts for more than half of the world's maternal and child mortality. Recently, health disparities have made the Black race more vulnerable in public emergencies like COVID-19 with limited health services. Second slide, please. Second slide. Can you zoom out?
Sorry, this is the slide as is. So do you want me to advance the slide?
Yes. With our diverse team of sustainable thinkers, we created an app which addresses. Next slide. Go back. That's not my slide. No. Okay, that's my slide. Can you reduce the size, please? Reduce it. Zoom out. Okay.
There isn't a way for your screen sharing.
Okay. With our diverse team of sustainable thinkers, we've created an app which addresses the 3 Ds of health disparities in communities, such as distribution of human and material resources, which includes COVID-19 test kits, PPEs, and health workers in communities. Secondly, the problem of data information about the minority communities. And lastly, the problem of demographic disparities. How does this app work? The Home tab on the app has a GPS tracker, which would enable community health workers send their locations when in need of health resources. This addresses the problem of distribution of resources and identification of underserved communities and populations. The second tab on this app is a data storage section, which provides health information about the community, like the number of health workers, available medicines, and test kits. This feature addresses the problem of health data or information. The third feature of this app is the plus tab at the middle, which contains the information displayed on the right-hand side of the slide, such as requests for health resources, shared data, shared stored data, and suggestion. Next slide, please. Now, once the community health worker turns on the GPS tracker and makes a selection from the plus tab, her location and information will be forwarded to the district health information system. With this app, the underserved communities like those of Rachel's would have the needed health services at any given time and location. Next slide, please. What happens after the implementation of our idea? 1. Increased vaccination across all children of Africa and other nations. Equitable distribution of resources. Quality health services for all racial groups. And finally, reduce child and maternal mortality. Next slide, please.
All right, and we're at time. Thank you. Open it up to the judges.
Hello, this is yeah. You never talk about how you're going to monetize it. What's the source of your revenue?
Okay, we plan on collaborating with stakeholders around the globe because this app will be useful to stakeholders like the community health workers and the district officers. So we plan on collaborating with state governments in Africa to gain revenue.
Thank you.
All right, if there are no more questions, we can move on to the next presentation.
All right, Team 50, One Health for All. You guys are up next. And then please be ready, Team 5, Co-Serve.
And just a brief reminder for our judges, when you're entering your judging forms, for the next team presenting, it's team number 50 in your judging forms. All right, so for the next team, if you can raise your hand.
Sorry, hold on a second. I've just been entering them using the existing, just one after
Yes,
the next
and
after the next.
we will fix that on the back end. But just from now on, if you can just use the team number that's presented here, that would be perfect. Thank you.
Okay, thank you.
All right, I'm unmuting the next team. All right, go ahead.
Thank you for giving us the pleasure to participate in this challenge. Our team name is One Health for All, Restoring Trust and Well-Being. I'm a 58-year-old African-American that lives in the low-income area in Louisiana. My family have a history of trusting the healthcare system due to deaths. With COVID, I'm starting to have some shortness of breath and fever. I'm scared to call the healthcare system because we don't trust them. Problem: the vulnerable communities, especially African Americans, have mistrust with the healthcare system due to history. How can we fix this with COVID pandemic? Next,
please.
I'm scared. Next.
I'm sorry, can you go to the previous slides, please?
You want the NGO slide or the implementation slide?
The NGO, please. We suggest NGO model, a bottom-up, top-down approach to build trust in the community. We use the community leaders who understand the language and culture to empower the youth. This is important because the youth will later become successful leaders that understand the culture that they grow up in and give back the trust within their own community. The way we motivate them will be by using arts, music, sports, bringing in celebrities, local champions. The youth will also reconnect to natural spaces like parks, significant ancestral lands, and spaces that will bring healing to their own community. Targeting the youth is the fundamental step to build healthier lives and families' trust, not only during the COVID pandemic, but also in the long run for future illness outbreak. Next, please. Our implementation will start first by raising funds for the NGO during the startup process, in which we collect data through surveys to understand what these people need exactly. After that, the fundraising, and we build app and website that provide and target exactly what the population is looking for. And through the app, we can also continuously test and improve people's need and encourage the youth to involve in building the NGO. The services that we provide ranges widely from education, healthcare connectors, create self-sustaining solution. And through the NGO, the youth will be the connector in their own community and help the elder people like John, the case that we present from the beginning, who don't know how to use the internet. Next, please. This is an example of our website model where people can search for local champions in their area that speaks their own languages and understand the culture. The website model also links user directly to the hotline with translator assistance and connect those who do not have insurance to social worker contacts in their community. Next, please. This is our team, and with our diverse skills from medicine, law, public health to engineering, we believe that this NGO model will heal the broken relationship in this vulnerable community. This is
In time, thank you. Open it up to the judges.
What have you learned from existing outreach efforts by hospitals already in these communities? So hospitals that are already trying to serve these communities.
I'm sorry, can you repeat the question, please?
Hospitals often already make efforts to outreach to local communities that they know have a lot of health burdens and have difficulty engaging with the healthcare system. What have you learned from those past efforts in designing this?
So the problem with the current social workers is that the population that we are targeting are actually like those people who haven't received healthcare for a long time. So there's actually like they refuse healthcare for like 3 to 4 years and they don't have access to social worker. And the only way for them to trust the system is actually through like younger generation in their own community.
We have also learned that community health workers have been very instrumental in working with their own communities, because it's where you get people who are just like you, who talk like you, and they come in and work with you. So some of these projects have worked internationally, and we believe that they can work also in some of these settings. And they have been successful in some parts, like I think the University of Pennsylvania.
All right, thank you for the presentation and for the questions. Thank you.
Right, up next we have Team 5, CoVServe. And then after them, if you guys can get ready, Team 8, Co-Free Transport.
Anyone who's not presenting, please mute yourself if you're done with your presentation. Only the people presenting should be unmuted. And of course, the judges and the hosts are going to be unmuted. All right, go ahead.
All right. Next slide. Next. Hi, I'm Onimechi Weke, and I want you to meet Kewe. He's a Nigerian, and he's not feeling well. He's worried he may have COVID-19 disease. In Nigeria, he has 2 options recommended by the public health system: go to a hospital or call the toll-free number. Either way, he gets triaged and a decision is made based on symptoms for him to get referred for testing. If he gets tested, he will find out if he is COVID-19 positive or not. Some cracks exist in this system. Next. Next. Kewe might not go to the hospital if he is one of 72% of about 200 million Nigerians who have to pay out of pocket for care. Next. Also, he might call the number and nobody picks his call. Even when he calls the system and gets through, he might get triaged wrongly due to human error and not be recommended for testing. Next. In all scenarios, we have suspect cases that are falling through the cracks. This is a problem. Next. And this is why we've designed CoVServe. It is a self-reporting surveillance system that is citizen-driven and automates the triage system. It is a process of collecting and processing data on symptoms that can supplement the government's efforts to identify emerging hotspots. Next. This is how it works. Next. We will raise awareness to let Nigerians know they can access a web link to a self-evaluation form we'll develop. The form will use a standardized symptom list from the World Health Organization. Next. Kewe fills out this form on his cell phone and his information is tagged for his geographic location. Nigeria has 97.5 million unique mobile subscribers like Kewe, a 49% mobile penetration rate. Click on next. Our application will be linked to an information technology system such as CompCare, which is open source, or IRIS, which is owned by InterSystems. And these are decisions that we'll have to make at some point in time later. The data from KEWA and others will be collected, processed, and analyzed using decision criteria built into our system. Next. Next. The result is we flag whether KEWA is or is not a potential COVID-19 case. Next. Now, if he is a suspect case, next, he gets to receive a screen report on his cell phone immediately, recommending that he seek medical care. Next. The other thing is the data populates on a base map of Nigeria with geographic location-specific bubble charts, and the size of the bubbles will indicate the number of COVID-positive suspects. Next. We then share our data with our proposed partners such as, next, the Nigerian CDC, and non-governmental partners working to prevent the spread of COVID-19, such as community organizations, partners in health, and so on. Next. To pay for this system, we are going to consider a public-private partnership model to leverage corporate investment, given that COVID-19 has made an unbelievable global case about the value of investment in public health. Thank you very much.
Thank you. Open it up to the judges.
Question. You know, with people hiding in Nigeria and not wanting to seek healthcare, or being afraid of being isolated, how do you address that? How do you help that?
So the system we have designed is intended to actually help the government and other organizations that are currently trying to get people tested to better identify where exactly these cases are erupting. And as for the individual, yes, people are hiding, but they're hiding because the care what they've heard about the isolation centers is not very good. And so I'm not quite sure what to do with that, but for certain, at least if people know that they are positive or that they're likely to have COVID symptoms, then they can do what they need to do within their capacity to protect themselves and their family members.
Thank you.
How does this compare to efforts already underway?
So there are efforts underway here in the United States, and also I've read about an effort in Europe, which is tied to one of the efforts in the United States, but I haven't seen anything of this nature in Nigeria, and I'm not aware of anything of this nature going on in Africa. I did, in speaking with one of the mentors yesterday, I did learn that there are similar systems, not exactly COVID related, but related to tracking other healthcare, other health issues. But those systems they go through the healthcare system. So what is different about what we're doing is we're going directly to the citizens. So we're engaging citizens.
All right, thank you. Thank you for the answers and the presentation.
All right, up next we have Team 8, which is Co-Free Transport. And then after them, could Team 15, Cocoon, please be ready to present.
All right, go ahead.
Hello, our project is Co-Free Transport, an automated solution to the contact tracing problem. Next. Next. As our economies open up, a second wave is imminent. In order to combat the second wave, we need a more effective way of contact tracing. Contact tracing today is currently unable to tackle public transportation. In New York City alone, there are over 8 million public transportation riders, while over 85% of public transport users are from lower income households. With this statistic in mind, we'll be highlighting the benefits of this technology for Harold, a low income, elderly, essential worker who does not have a smartphone. Next. Let's look at the current framework. The process in play today relies on case interviews by human contact via phone call. They will then create a list of known places visited and contacts. They then trace and monitor contacts of infected people and notify them of their exposure. This system lacks accuracy because it relies on people to remember who they've been in contact with and where they've been. Scope because it's limited only to people you know, mostly family and friends. And scale because doing this in large cities such as New York City requires massive manpower and money. Next. Our solution is twofold. First, smartphone users can download an app, while non-smartphone users like Harold mentioned earlier can enroll through text message. Users will be assigned an individual QR code. Users then scan this QR code at check-in and check-out. Infected users will then either self-report they've been infected, or we also hope to partner with testing centers to scan QR codes and notify a centralized database of a positive result. COVID positive cases are flagged in the database, and users with overlapping location and timestamps are notified of possible exposure. Next. These are some wireframes of the enrollment process, the self-reporting process, followed by the notification that users were potentially exposed, information on symptoms to look out for, and information on their local testing centers. Next. So a big question, aren't Google and Apple already working on this with geoinformatics and location services? Yes, but our solution is more accessible as it's functional in both smart and basic phones, reaching a key underserved demographic that benefits from contact tracing. It's more private as it's not on all the time geo-tracking, and it offers enhanced geographic specificity with strategic placement of QR scanners. Next. So our business model will begin with piloting and a staged rollout. In partnering with NYC transport authorities, we will install inexpensive QR scanners on each bus, start with selected bus routes, then expand to other public transport. We will launch with self-reported COVID data, then integrate with testing centers. Our greatest implementation challenge is developing relationships with numerous stakeholders. While still difficult, we have several team members who are NYC Gov employees to help navigate the environment. Initial uptake and ensuring use will also be difficult, but since users do benefit directly from the program, we believe adoption can happen. Next. This solution can benefit any organization that has public health of a population and in mind, and COVID transport can also be more lucrative. This includes partnering with private employers, especially those in the service industries and retail industries who work in confined spaces, and large multi-floor office buildings where each office floor has its own unique QR code. This is also possible with other public health outcomes like foodborne pathogens. Next. Last but not least, we have the right team to bring the solution into reality. Our team has a diverse background spanning from clinical and basic research, healthcare professionals to designers, students, and public sector expertise. Thank you.
Got a question.
Yes.
How do you monetize it, or what's your source of revenue?
Sure. So for the pilot program, what's nice is that the MTA already has QR scanners in place. So once we show that the model is possible, we talked about some type of incentivizing program with companies getting people to get discounts or to scan. So that would be some type of monetary value there.
And this is Diana. I just add that so we plan on doing the pilot program. Our services would be free or minimal, and the New York City would pay for funding for hardware and installation of the pilot rollout. But after that, we would charge for a broader rollout, either if it's with the city public transit or an employer or a retail center.
Thank you.
How would you pilot the non-smartphone users where they don't have QR code scanners on their phones?
Sure. So we talked about a SMS model with that. So they would send a text message. It would be a notification for this pilot model, if we're talking about that, from the bus. And we would inform the users to please text this number. They would receive a QR code, and then the scanner would be right next to kind of that metro swipe station. And we thought buses were a good model because the bus driver is right next to the scanner. So that's why we use that as the model. So a text SMS.
Thank you.
All right, thank you. We'll move on to the next team.
Okay, up next we have Team 15, Cocoon. And then after them, to get prepared, Team 54, Santanet.
All right, Cocoon, if you can raise your hands. I have Aniket.
Can you hear me?
Yes, we can.
Okay, perfect. Next
All right,
slide.
you can go ahead.
Meet Marie. Marie is a strong, vibrant woman who's been diagnosed with leukemia. She's scared, constantly facing news articles stating how dangerous the pandemic is for immunosuppressed individuals. She is anxious about the lack of clear information, overwhelmed with uncertainty, and questions whether to delay treatment till after the pandemic. Next. Marie is not alone. There we go. There are almost 44 million people diagnosed with cancer worldwide and almost 38 million with HIV. In a time when they need support, patients are forced to live in a constant state of isolation and fear. This is a significant global health issue. Next. We are Cocoon, and we want to improve patient mental and emotional health remotely, both during the COVID crisis and beyond. We are a diverse team with backgrounds across public policy, design, and software, and we personally relate to this issue because we have family members facing these challenges every day. Next. This is the landing page of Cocoon's website, where users are welcomed into the platform. From here, they can choose between 3 different solutions that we offer. Next. These solutions are data, community, and tools and resources, and they help solve the lack of information, uncertainty, and confusion regarding next steps. Next. For data, our modern data visualization techniques will help bridge health literacy gaps, inform decisions regarding next steps, and reduce avoidance of treatment out of fear. Next. This is a little bit of a mock-up of some of the data that we want to be able to show to our users. Next. By helping patients connect with others, the platform enables them to get advice and support from people who have personally dealt with these challenges and be reassured through personal connections. Next. Again, this is another mock-up of how patients may chat and interact with each other in real time. Next. Lastly, we want to make sure that patients are able to define their issues better. We want to connect them to the proper resources and tools that are publicly available and positively impact their quality of life remotely. Next. Based on our market research, Cocoon will be able to provide more interactive and curated content than any other social patient platform on the market today, including better data, personalization, and resource capabilities. Next. Because of this differentiation, we intend to partner with insurance companies, hospitals, and healthcare organizations. Improved mental and emotional health can increase treatment adherence, aligning Cocoon well with these institutions' bottom lines. Next. To get off the ground quickly, we will leverage publicly available data sets and APIs from existing social media platforms to help build our network quickly and efficiently. Next. With your mentoring and guidance and funding, we believe we can develop a pilot by this fall and build up to multiple customers by the summer of next year. Next. Here at Cocoon, we believe that we can positively impact patient emotional and mental health through better communication of data and improved access to targeted research. Next. Thank you.
Hi, this is Ethan. My question is about your funding model. It seems that your funding model is basically to sell your audience to players, existing large players in the healthcare system. Did I understand correctly?
Not exactly. So, of course, we would love to have had more time to get into it. There's a couple different models that are available. We can white label our product so that for a particular healthcare system, we can partner with that healthcare system to ensure that their own patients are actually more catered to and have the resources and kind of community built so that their emotional and mental state are better. That's one model that we can pursue. The other model is more that out of municipalities and state organizations, those sorts of people would be able to, those sorts of organizations would also be able to partner with us as a more of a public health initiative. We don't intend to necessarily collate all the data from these users that are on the platforms and serve them up without some sort of encryption and anonymization. Long term, we may be able to serve that analytics up for public health research, but again, that's further down the line.
Thank you.
Is part of the data that you're collecting looking at wait times? Is that what I saw with that slide?
Yeah, so there's different APIs that are available from hospital systems and other kind of public health systems that we've been finding, where you can actually see what the wait times are in the clinics and places around you. In other cases, you can also check like what traffic is like, how many people are moving around based on what the camera feeds and how, where that data comes up from 404 and some of these other government organizations as well. So there's a lot of data streams that we want to leverage.
Thank you.
Yeah.
All right, and that's time. We'll move on to the next team. Thank you.
All right, next team up is Team 54, SantaNet. And then coming up after them, Team 16, Beyond the Words of COVID-19, or BTW.
All right, whenever you guys are ready.
All right, can you see me?
Yep.
All right. Hello, we're Santa Team. Ever since the pandemic forced us into lockdown, the world has adopted online platforms, but orphans have been left behind. I met Kofi at the
Krishna Orphanage in India, where I was volunteering for Dental Care Foundation. This little girl's smile was immediately imprinted in my heart. Unfortunately, since the lockdown, Krishna Orphanage has experienced a 50% decrease in corporate grants, and there has been 0 events since March. Next, but the loss of the crucial face-to-face connection between volunteers and these children is what cuts the deepest. The pandemic has increased compassion and willingness among people to help, but they have no means to do so. Orphans all across the world are facing the same problem. What is the solution?
SantaNet is a platform to connect volunteers with orphanages. If you run an orphanage, you can open your mobile app or website and post an event. Next, if you're a volunteer willing to donate time or money, SantaNet lets you simply donate money or register to participate in an event. What's an event? As an example, I'm a college student who can teach elementary math. So I can open my app and hey, Krishna Orphanage has an event, reach out and teach. That says math, English, or dance. If you know it, come teach it. Perfect. As you can see, this is an online event on Zoom. There can also be an offline event where I can actually visit the orphanage, depending on the situation of the lockdown, of course. Next. So we actually went ahead and deployed an event for next weekend, Beat the Pandemic with Pains, and invited sponsors to donate money for art supplies. Our event has already attracted 12 donors in the last few hours. We intend to share the children's art with donors after the event to emphasize on personal connection. Next.
Just checking, do you guys want to be on the painting contest slide?
Next.
Is this the correct slide?
Oh, I can't see
Right,
it.
we can go on.
Next slide, please. Yeah. The next one.
So through market research, we stand out among our competitors due to our remote interactions and events, our local volunteering network, and our app being able to run on minimal internet speed. Next, we plan to partner with nonprofit organizations like United Nations Volunteers to connect with volunteers and software developers. And we also intend to fund the operations through corporate advertisements on our app. Next. So SantaNet is, we'll start in an orphanage in India, where we'll learn and grow to over 50 orphanages there in the next couple of years. Then we hope to expand to Nigeria and eventually help children like Kofi across the globe. Next. So lastly, SantaNet is brought to you by our amazing team across the globe with extraordinary backgrounds and backgrounds that include outstanding efforts in volunteering that make it clear of the importance to empower children. So thank you for your time, and I can open the floor to any questions.
I got a question. So, I mean, using app to recruit volunteers is well established. So what differentiates yours from other apps, source of inviting, volunteers to different settings?
Yeah. So we are building a specific niche to not only bring together volunteers for these organizations, but they can easily reach out to a pool of several volunteers to organize a specific event, right? So say I want to organize an art event, I need a vast set of skills. So you can easily locate these volunteers near you with their profile, portfolio, and availability, rather than wait to see if the volunteer used the last time is available. So instant availability, portfolio, and organization. Also, one volunteer can mobilize others on the app. For your even most existing apps don't have that option.
I also have a question. Who is monitoring the content of the events to make sure that it is children compatible?
So organizations, so we only give access to the nonprofits, the orphanages to post the event. So these organizations we get them on board only after checking their background, like their social media presence, maybe, so like in India, we have something equivalent to the SSN, right? So we'll make sure we background check before we get them on board.
See.
All right, if there are no more questions, we'll move on to the next team.
Thank you.
Thank you.
Thank you. Okay, up next we have team 16, Beyond the Words of COVID-19. And then after them, we'll have team 19, Sage.
So team 16, if you can raise your hand so I can unmute you.
Thank you.
All right, go ahead.
Okay. Apprehension. First slide, please. Thank you. Apprehension, confusion, fear. These emotions are infecting the minds of our elderly, and with good reason. 80% of COVID-related deaths in the US have been adults aged 65 years and older. Next slide.
In addition to the current pandemic, the elderly are faced with what the AMA calls a silent epidemic, low literacy. 29% of the elderly in the US only read at a 5th to 7th grade level, yet over 50% of healthcare information is written at or above a 10th grade level. Poor health literacy is a stronger predictor of health than age, income, education, and race, and an indicator of poor health outcomes. Next slide.
Another risk faced by the elderly is their limited access to technology for virtual health information and services. Nationally, 1/3 of the elderly say they've never used the internet, and 50% do not have the internet at home. Next slide.
We have assembled a team of diverse and experienced individuals across the globe with existing community networks with organizations like the WHO and a unified passion to provide health literacy for the elderly. Next slide.
Our team plans to launch Beyond the Words of COVID-19, a service dedicated to educating and empowering the elderly. Next slide.
Our business model has a user-centric and two-phased approach, and we've deviated from the traditional use of websites and mobile applications to a method more familiar to this group. Next slide.
The first part of our business involves a service that adapts existing COVID-19 information and resources to a more readable format for individuals with low literacy.
These changes include the use of active voice, shorter words, and conversational language, and the readability score can be assessed by tools including the SMOG Index and Flesch-Kincaid readability system. Next slide.
Our calling service, which we plan to host using an automated dial-in system, is the main portion of our company. It will operate via pre-recorded messages that contain various COVID-19 resources that the caller can navigate through. The service phone number will be provided in community resource guides and included in the adapted materials. Next slide.
This service will have information on prevention, symptoms, news updates, mental health, and local resources such as food delivery, financial assistance, and community outreach. Callers can dial 0 for further assistance through a representative. Next slide.
Our organization plans to partner with national organizations such as the CDC, NIH, and WHO to adapt existing resources to low literacy levels for the elderly. Paid and trained employees will act as liaisons between these organizations and train volunteers to tailor these resources. In return for our services and making these resources more accessible, we aim to get funding and promotion through these organizations.
Ultimately, we hope to transform current fears of the elderly during the COVID-19 pandemic into strengths through accessible, pertinent health information and to expand to other low literate groups in the future. Thank you.
We can go to the next slide. And the final slide is just thank you.
All right, judges.
I have a question. What is your strategy to initiate the collaboration with those organizations?
Yeah, so to initiate these contacts, we would first branch off of the personal connections that our team has with organizations like the World Health Organization. So we would start forming contacts by reaching out to personal contacts, and then through social media and emailing, we hope to develop a network with officials from different organizations and begin our volunteer and employee recruitment.
Hi, this is Ethan. Creating and maintaining a library of content that's appropriate for your target audience is a significant burden. Are you anticipating doing that yourself, adapting other people's content, or simply connecting to existing content that you think is correct, or some other strategy?
So basically, to create this contact, yes, we would be branching off of existing resources from these public health organizations and research institutes. And we would be working on tailoring these resources to low literacy levels.
Thank you.
All right, if there are no more questions, we'll move on to the next team. Thank you.
Thank you.
Sorry, give me 1 second. All right, team 19 Sage, you guys are up. And then preparing to go after them is team 22 ENY.
All right, then I will begin. Next slide. Good afternoon. We are Sage, Team D19. We are helping blind and deaf communities easily access healthcare providers. Next. This is Sarah, a 51-year-old woman who recently lost her vision completely. She was in contact with her son who tested positive for COVID-19. She started coughing today and is worried she has coronavirus. Unsure how to schedule a doctor's appointment or where to go, she is worried she will die at home alone and has infected everyone around her. Next slide. Last year, 20% of people with disabilities were unable to access care compared to 9% of people without. This is double the access gap. Next.
Our solution is a voice-enabled conversational AI mobile app that will assist the blind and eventually deaf communities in accessing healthcare providers and allow contact tracing during COVID algorithms of natural language processing with medical data, recognition, and voice activation. Sage will be processing the conversation real time and determining the course of action using our defined algorithm. Next.
Sage is able to serve as a triage tool, symptoms, exposures, and risk factors to help find the right care for the user. Next. Sage also identifies emergencies by asking for red flag symptoms. It automatically calls EMS based on the patient's location while checking for responsiveness until help arrives. Next. Sage also facilitates contact tracing to help mitigate the spread of COVID-19. It will converse to identify the user's zip code and ask who they have been in contact with. Next. As a pilot, our serviceable market is blind individuals and hospitals in New York. 4.1% of New Yorkers are blind. There are 213 hospitals in New York. Based on conversations with multiple executives of a large hospital network in New York, our licensing fee will be $10,000 per year, generating a recurring revenue of $2 million, while the total addressable market is much larger. Next. We are primarily a B2B business and get our revenue by selling hospitals an annual license. We will also offer a freemium model for individual users to create a demand to enroll more providers. Next.
Same Poly for users all over the globe and incorporate sign language for the deaf community and eventually expand to broader customer segments. Next. We have developed a prototype, so let's meet Sage.
My name is Sage. What is your name?
Sarah Walker.
Hello, Sarah. How are you feeling today?
I have a high fever and I can't stop coughing. I'm blind and I can't go to the hospital. Please help me.
Do not worry or leave the house. Sit down and where you are right now.
I'm at home, 89 Bellevue Avenue, Ocean.
I have contacted the nearest hospital, Mount Sinai, South Nassau. Will be.
Thank you. Next slide. Our team is a diverse bunch of individuals uniquely suited to address this problem. Thank you for your time.
And time. Thank you.
Judges?
Is this platform going to be built off of iOS or their phones? Is this going to be an Alexa app?
Yeah, thank you for the question. It will ideally be an iOS and Android.
May I answer this?
Yeah, you can also.
Yeah. So the support will be for Android and iOS right now, and that there are existing applications that allow the blind to open apps using voice command. And once they open it, our app Sage Activate, and that will help them access it without any. Thank you.
Thank you.
Who are your competitors?
Yeah, so our competitors, we have some indirect competitors and some direct competitors. Our mainly direct competitors is LivePod. It's a caregiver speech-to-speech app to help assess people. However, our advantage is mainly user experience, patient journey, data privacy, and also real-time support. And there is currently no other available tools that will provide the access that we will provide to the blind and deaf population.
All right. Thank you for the presentation and answers. Thank you.
Okay, up next we have Team 22, ENY or Annie, and then after them we'll have Team 40, MedPal.
All right, go ahead.
Good afternoon, colleagues. I'm Terrence Blackman. I represent Team East New York. Let me introduce you to Sharon. Sharon is a resident of East New York, Brooklyn, zip code 11239. She's 49 and she has been diagnosed with type 2 diabetes. East New York is the community with the highest fatality rate from COVID-19 in New York City. For perspective, this rate is 60 times the average death rate of white New Yorkers from COVID-19. Next slide, please. Sharon is not alone. She is one of 1,820 residents of East New York who suffer from diabetes. She is among the group most at risk for severe complications due to the coronavirus. Diabetes management by way of nutrition can decrease Sharon's susceptibility to COVID-19 complications. But because she lives in East New York, Sharon does not have easy access to fresh and nutritious food. There has to be a way for Sharon to access affordable, nutrition-friendly food. Next slide, please. There is a way, and we call it the neighborhood basket. With the tap of a button, Sharon can order food, groceries, and have it all delivered to her. Meals, grocery baskets with suggested recipes, and free meals from participating city initiatives. Next slide, please. We do this by way of a platform which connects a network of community partners with institutional partners to solve the diabetes appropriate food access problem for Sharon. Well, we've already garnered the support of key religious community figures, and the Queens College of the City University of New York has expressed some interest in our neighborhood market. Next slide, please. Our business model. We anticipate multiple revenue streams. We have identified sponsor organizations, restaurants, community partners, and we're looking at state grants and possibly partnering with value-based care organizations. We note here, why stop at East New York? We estimate that there are at least 4 million Americans impacted by food insecurity and diabetes. And we have not discussed the other chronic diseases such as obesity and hypertension to which neighborhood basket can easily be applied. The challenge is skill and will. It takes a winning team to make this happen. Next slide, please. We have it. Shireen has extensive experience in diabetes management. Aline is a data scientist with a background in community health. Dana is a technologist with healthcare background, and I am an academic with a strong community network. We are passionate about solving the food access problem for Sharon, and with your investment of a minor sum of $100,000, we are ready to continue our work tomorrow. Thank you.
Thank you, judges.
Question. You know, there are a lot of, grocery stores that will deliver food. Is this your a company trying to deliver food that are catered to diabetic patients, or just, to help them plan their nutrition? Or
yes, so our focus is explicitly to the diabetic patients, and to add this educational component and the component that is related to the community assets that can support the education as it relates to diabetes.
Thank you.
All right, if there are no more questions, we'll move on to the next team. Thank you.
Thank you.
Okay, up next we have Team 40, MedPal. After them, we'll have Team 27, Better Together. So MedPal, go ahead and raise your hands, and then Danya will unmute.
Okay, go ahead.
Last week I got a text from my aunt. She told me if you eat 3 papayas a day, you can get guaranteed immunity to coronavirus. I thought about it and said, how could that be? Like, where do you get this information? And she said, I got a WhatsApp message from one of my friends. And so I began thinking, how many people like my aunt are out there wondering whether or not this information is correct and maybe blindly accepting it? Next, please. We are MedPal. Want you to meet Mei Zhang. She's a 55-year-old single mom of 3, immigrated from China in 2017, lives in Flushing, speaks limited English, stocks groceries, and is an essential worker, exhibits symptoms of COVID, but doesn't know exactly where to go to get resources for this. Next. Please. Misinformation spreads rapidly in underrepresented Chinese-speaking immigrant communities in New York City. We must deliver accurate and culturally appropriate information regarding COVID, or we risk falling victim to a second wave that disproportionately affects these communities. Next. So just in New York City alone, there are 300,000 foreign-born Chinese immigrants, 60% of which have limited English proficiency, and 14% of which are uninsured. Next. So our solution is MedPal. We connect under-resourced Chinese immigrants in the community with Chinese-speaking medical students to prevent misinformation, strengthen community trust in the medical system, and develop new friendships within the Chinese community. Next. So we have 2 main groups in our system. We have the Chinese immigrants with language barriers. They don't feel as comfortable asking for medical advice, medical help. They don't know if they can trust the medical system or if it's financially viable for them. So with this platform, they can get the correct information, get community resources, and strengthen their trust in the system. Chinese-speaking students from medical schools, nursing schools, dentistry schools, and such can get clinical hours and get vital community health training and experience through participation in this platform. Next, please. Here's a quick, so we plan on partnering with hospitals, medical, and nursing schools. We want to empower local Chinese businesses with ads on our platform. We are easy to scale because we can add support for different ethnic and language groups and expand to other cities without geographic barriers. Next. Here's a quick look into our website. Next. And an example conversation that May had with one of our volunteers. We are available in video platforms, text platforms, and call platforms. Next, please. We have a wide variety of talents and come from a wide variety of backgrounds. 2 of us live in New York, and we have a Chinese population members and we are directly invested in the fulfillment of this promise to end misinformation today. Thank you.
Thank you. Judges?
What's your funding model?
So our funding model comes from a primarily ad basis with local Chinese businesses putting their ads on our platform. We also plan on partnering with medical schools and hospitals in local regions. So in New York, we would target hospitals and medical schools specifically.
Yeah, and just to add on top of that, we will work with community resources and community-based organizations. So in New York City, that, for example, the Bloomberg Philanthropists, and also work with local resources like social service agency, like the Chinese Nursing Association, for example, on top of the hospitals and schools that we are already partnering with.
Thank you.
Thank you. Thank you for your question.
All right, if there are no more questions, we'll move on to the next team. Thank you.
Thank you.
Thank you.
Up next, we have Team 27, which is Better Together. After that, quip.u, please be ready to present.
Am I audible?
Yes.
Next. Better Together. Through various reports, it was found that around 9% of low income and 20% of vulnerable population have surveyed have never been explained the existing healthcare facilities which exist. And now, when 30% of the population who lost their livelihoods due to COVID-19 fear that they would have extra reliance on the public healthcare system and don't know enough about it. Next. We identified racial and ethnic minorities are at a greater risk, especially those with poor health literacy, which leads to difficulty in accessing, understanding, and finding culturally sensitive healthcare resources, leading to lack of healthcare solutions that are suited to their individual needs, culture, and socioeconomic status. Next. The problem we pose is how might we empower people with poor health literacy and limited resources to navigate through complex healthcare systems by promoting health literacy, personalized and culturally sensitive care through community effort and agency. Next. What must the solution do for disadvantaged communities to feel comfortable in times of medical need? It is important that they, 1, understand the healthcare they need, 2, feel a sense of agency and trust in healthcare facilities they choose, 3, establish metrics for judging healthcare facilities. Next. Introducing Better Together, an app for finding local healthcare facilities which are rated by local communities, that is, people living in the same vicinity. Next. Through pre-existing keywords, vulnerable population are easily able to search healthcare facilities they need and find necessary healthcare services. Next. It allows one to identify with a community of patients and give details about oneself for a better match with health facilities. Next. It uses a unique filterable rating system so users can leverage insights from those demographically similar to them. One could start unfiltered or adjust to review rating scores by specific demographic characteristics. Data and ratings are given by local users themselves, local nonprofits, or sourced from existing databases, being truly by people for people. Next. It uses easy to understand icons to communicate resource availability and facility accolades given by other users in vicinity to various healthcare facilities around them, as shown on a map. Next. Finally, once a person has been matched to their desired healthcare facilities, they can find their way to the facility. Next. Why will it work? Because diversity matters. Studies suggest populations receiving culturally competent care are more engaged in preventive care. Next. Our competitive advantage is our primary focus on culturally competent care by unique rating system that is by people for people, by connecting people to communities they resonate with, and by simplified visual search. Next. Our idea is scalable, adaptable, empowering. Yes. Next. Team Better Together is a team with designers, clinical researchers, nurses, and data scientists, all passionate for participatory research for data making. Next. Thank you.
Thank you, judges.
Hi, what's your funding model?
So I'm going to talk about the funding. We just expect that we hope the governments will fund it, local nonprofits will help give us some, help get the system off the ground. And we expect to give them some sort of, and at some point maybe do some advertising, but to get the nonprofits involved, give them the ability to tell us who we can have advertised, so that gives the system more credibility. And maybe sell slots to the government for local health emergencies or to target certain populations that have certain health disparities. Let's say a population is overly burdened by the opioid epidemic. So maybe we could charge for some messaging or charge for some emergency services or something like that. So just public-private partnership mostly, and then maybe some add-on things.
All right.
Thank you.
Oh, Yes, thank you for the presentation and answers.
Thank you.
Okay, up next we have Team 2, quip.u, and then after them we'll have Team 56, COVID Mobility Tracker.
This is a quipu, an ancient Inca device for recording information, and we are QuipU, a team that equips you with the right tools to understand indigenous communities, providing them the independence they need. Next. Yesterday, we contacted Apu Lizardo, the president of IDESEP, and there are three main problems: lack of data organization, lack of resources, and lack of demand and supply. Next. This is an ethnocide. Next. He is collecting data manually from each Amazonian community through prepaid cell phones, but only 109 communities have phones. Next. As we can see, data for these 5 states is non-existent. All the death and case statistics do not include indigenous communities. Next. If Bella Vista was a country, it would be the first country in the world by infection rate. The manual database is rudimentary. The indigenous leaders commute to charge their phones. There are no supplies, and their income sources have been deeply affected. Next. So what is QuipU? It's a digital platform that serves as the main communication network among indigenous communities. A mapping system enables indigenous leaders to input and manage their own data, identifying hotspots that need more assistance. Without depending on outsiders, there are 3 main steps. First, the tribal leader will use solar charged phones to communicate with other leaders and practice social distancing. Second, the data will be inserted into the database through the app. And third, this will be displayed on the digital map system. Next. This identification allows the existing indigenous COVID task forces to track cases and effectively allocate supplies. Next. Here is our timeline, which tackles testing, training, impact measuring, and market expansion. In the span of 1 year, more than 2,000 communities will be impacted. Next. The impact is monumental, but the cost is minimal. So what is our business model? Indigenous people have stories that the world has not explored yet. Through technology, communities can share with the rest of the world their cultural activities and sell their experience, changing the whole perspective of what tourism means and diversifying also their economy. Next. But we are different. Through QuipU, we apply our understanding of human-centered design to ensure our solutions solve specific pain points. We respect the culture and preserve their privacy, while equipping them with the right tools for self-sovereignty. Next. This platform could be applied all over the world. For example, Google is already bringing Wi-Fi to the Amazon and Africa through air balloons. Next. These are our potential partners. Next. Across 4 different continents, Hans, Gabriela, Carlos, Cho, Hoden, Victor, and me, Valerie, are committed to ensure that indigenous people are not forgotten. Neglecting the guardians of the earth is neglecting our own history. We have the right problem and the right team. We just need the right partners. Next. Apu Lizardo carries thousands of stories to tell, and the world has decided to ignore it. Are you going to ignore it too? Thank you.
Question. So what's your revenue model?
Next, please. Next slide. Okay, Carlos, you can go on. Can you please unmute Carlos? Can someone please unmute Carlos? Thank you.
No worries.
Hi.
Yes, I don't see him raising his hand. Let me just check. All right, I just unmuted him.
Okay. Yes, so we plan on selling experiences. Since 2017, Airbnb has included experiences in their model, and we plan to adopt the same model. It's shown the growth of $10 million since then. And as well as advertising through the solution that we provided in a similar sense that Snapchat does it, as well as providing online classes and expanding their culture through virtual and also in-person contribution once COVID-19 is over.
Thank you.
Mm-hmm.
Any other questions?
Sorry, just housekeeping. What team number are you?
002.
Thank you.
QuipU. Thank you.
All right, if there are no other questions, we'll move on to the next team. Thank you.
Oh my God.
All right, guys, can you just all mute yourselves?
Okay. Up next, we have Team 56, which is COVID Mobility Tracker. And then after them, we'll have Team 73, which is Co-Protect. So Team 56, go ahead and raise your hands, and then we'll unmute you.
And for Team 2, if you can lower your hands and mute yourselves.
Hi, everyone. Can everyone hear me?
Yes.
Awesome. Next slide, please. So we are Team 56. These are the people that have worked with me on the project, and we have a very talented team of software engineers, data scientists, bioinformatics, and people working in the public health industry. Next slide, please. So our problem that we have identified is how can we quickly and effectively track and quantify COVID-19 hotspots so we can most effectively protect vulnerable populations from them. Next slide, please. Next, please. So the problem is that the COVID spread lacks accurate representative data on a very local level. So we are targeting local governments as our end user, since municipal and township directors are in charge of sort of creating policy at the local level. This solution will allow them to monitor the spread of COVID on the county level and take necessary measures to improve policies such as social distancing. Of course, other end users include immunocompromised, uninsured, and other vulnerable populations, as well as the general population who would benefit from seeing this information. Next, please. So we had three objectives that we sought out to solve. One was finding a suitable metric. We chose mobility data and infection density based on a variety of factors. And the second one would be to have an accessible UI. We want vulnerable populations as well as the government to have as easy access to this information as possible. And finally, because we're going to be trying to get data from volunteers, we're going to have to, of course, provide security for this data. Next, please. Oh, sorry. And now we're going to talk about the solution. Next, please. So we decided on a two-pronged approach, as I've said before. First is the real-time hotspot tracker, and second is garnering participatory information. Based on security, what we decided to do was to only have the zip code and put it into a 20-mile radius. We're not going to collect any other information other than symptoms. And that way we can ensure that the user's information is protected. Again, this would be incredibly helpful for governments to both receive this comprehensive first-hand data as well as make a decision using our hotspots. Next, please. So our COVID data sources, we listed a couple that we are planning on using, but one I would really like to bring up is the community mobility report. This is taken by Google, and it includes data on the county level, and it includes very detailed data about which aspects of movement people have started to either turn down or turn up based on since the COVID pandemic has started. Next, please. So this is the infection risk index that we've developed based on a model in a Goal and Sharma paper. And this is just basically measuring how mobility between communities affects infectivity. Next, please. So this is now development. Next, please. So for the code, we're planning on hosting a Flask server. We're mostly going to use Python, Plotly, and the Google Map API in order to plot all of our data. And we're hoping to host it on AWS. Next, please. So as for the web app format, we're going to have two UIs. One is the health evaluation form, where you can sort of post whether you're feeling symptoms or whether you have actually been tested for COVID. And then the other one will be the COVID hotspot map, which is a plotty choropleth map. Next, please.
And time. Thank you. Open it up to the judges.
So your hope is to be your customers are local governments and other local authorities.
Yes, the idea is that we could have the information would be accessible to the general population because we're going to be posting as a web app. But one of our main target audiences would be local populations because they can most effectively use this data to see how their social policy, to see how their social distancing programs and other policies are working.
And are they your source of funding?
For funding, because we're going to be hosting as a web app, we don't need much funding. We need probably two things: server host. Sorry, we probably just need server host, as well as Google API funding, and we can easily achieve that either through partnerships with AWS, which does have credit for nonprofits, as well as through crowdsourcing, and eventually maybe government contracts. But we probably won't need that much money at all.
Thanks.
Yep.
All right, if there are no more questions, we'll, sorry, Ethan, go ahead. Do you have a question?
No,
That's
I asked
Kate,
already.
sorry.
Okay,
sorry. Just curious of what makes this any different than, say, COVID near you and other crowdsourcing applications that are available?
Yeah, so the main differentiating factor of our solution is the implementation of mobility data. So mobility data is how much people travel to and from certain places. And Google, again, collects this data, and we're planning on using it to sort of enhance the COVID tracking, because we believe that mobility can really affect the amount of spread of COVID populations, as well as we are using this data to sort of target local populations, because there's huge variation of COVID impact between local populations, and we think that this will alleviate some of those problems.
Thank you.
All right, we'll move on to the next team. Thank you.
Thank you.
All right, we're at our last team. So Team 73 Co-Protect. You guys will be rounding us out today. So thank you so much for everyone for staying on the line. Team 73, go ahead and raise your hands and then we'll unmute you.
Yeah, so we are Team Co-Protect, and yeah, so we are Team Co-Protect and will be protecting people through our innovative product UVC mask, which is high-tech and cost-effective solution. Next. Yeah, so we will be going through few of the pain points, like the very first, like the filtering capacity of available products into the market. Like N95 mask has only 95% of efficiency. Also, it not destroy the virus cells, just it avoid it to enter into the mask. So it also need extra sanitizing source and could not be reusable because it is risky after 8 hours. So which causes a short lifetime of the mask and also is not affordable to everyone. So next. Next, please. Next slide. Yeah. So yeah, the previous one. Yeah. So here is our innovative solution UVC mask, which is used of the scientific principle of UVC radiation technology, which is ultraviolet radiation technology, which destroy 99.9% of the viruses and bacteria cells, and is a nearby and the time lasting of our solution is like 1.5 years, and it is reusable. Also, it is 100% safe from UVC effects upon human body because we had fixed the UVC non-leaking chambers. So next slide, please. Next slide. So here is our two proof of concept models, which we are using UVC light radiations, which is a range of 253.7 nanometer. Next slide, please. Yeah, so here is our 3 manufacturing models of the product. Like the very first model is we can use normal public can use, like the police staffs, our daily users, local customer can use the first product. Second model is for the riskable zones, like the doctors, health workers in the hospital can use these types of models of the mask. So and the third model is about it can be integrated with any other mask to increase its efficiency of the filtering system. Next. So the very first two models of our, we will discussing few of the key features of our solution. So very first cost is like $3.29 US, and it can run up to 5,000 to 8,000 hours and is 99% efficient to destroy the viruses, and it is having a self-sanitizing function, and it can be rechargeable after 13 hours and 100% safe from UVC effect. Also, we are getting a warranty upon UVC light of half year of warranty. The second model is like its cost is like $19.74 US and can run up to 10,000 hours. Also, it have a 99.9% efficient to kill the viruses, bacteria. Also rechargeable after 15 hours and 100% safe from UVC effect, and have a self-sanitizing function and 1 year warranty upon the UVC light. Next slide, please.
Thank you. Open it up to the judges.
I have a question. Maybe I missed it. Where this UV light is going to be exposed exactly?
Yeah, before the mask, before the entering, the very first the mask is like at the stage of the nose, and before the mask there will be a small chamber where the UVC light will be fixed, and the very first the air will be going through that chamber, and after it will be going into the mask.
Okay, just to clarify, will it expose on the skin or another component of the mask?
No, just we are fixing one chamber, and the air will pass through into the chamber, and air will be totally sanitized, and air will be totally treated. After that, air will be go into the mask. So that's why there will be not any effect upon the human body of UVC effect.
Have you thought about, people in general, people are just going to be very concerned, even though it's not going directly to UV light, it's not directly touching the human, it's just, the perception that there could be potential exposure to UV light, and how will you be able to demonstrate that that is not an issue to be concerned about?
And to echo that, the World Health Organization just launched, as far as I know, a warning about the UV light related technologies because there might be an exposure on skin and will not be ideal.
Yeah, so that purpose, we gone through a few of the international research data like Scientific American, where it was shown like UVC light can destroy the viruses, but it also affect upon the skin. So that's why we fixed a chamber, which inside only the chamber there is a UVC light. Outside of the chamber there will be non-leakage of the UVC light. So that's why this mask is 100% safe, we are telling, because there will be non-leaking of the UVC light outside of the mask.
Got it.
With that, it's time. Thank you all so much. This wraps up all of our presentations. We have heard some really phenomenal ideas tonight, and it's really a reflection of all the hard work that all of the teams have put in this weekend. I really want to say big congratulations to all the teams on a job very well done. I'm very impressed by all the ideas that were developed in such a short time period. I know that the judges will probably have a very hard time deciding on the winning teams. For our judges, please join us in the judge deliberation Zoom room. The link is in your judges channel. We will plan to begin deliberations at 3:30, so in 10 minutes. And for the rest of everyone on the call for participants, we will be coming back together as a group with all the hackers from this weekend for all the tracks at 4 p.m. Look for the link in the Slack channel, and the link is also up on the slide. Congratulations to everyone. We will see you shortly.